Hello, everyone. I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota. We're continuing with our Anesthesiology 101 lectures. Today, we're discussing the Airway Basics. We have a couple different learning objectives. We'll discuss how to perform an airway exam, how to perform mask ventilation, how to use a laryngeal mask airway, and contrasting that with an endotracheal tube, how to perform laryngoscopy, and then using different adjuncts during intubation. So how to use a McGrath and how to use a bougie. So the first component of the airway exam that I'd like to talk about is the Mallampati scoring system. The Mallampati scoring system is a way to evaluate and communicate the anatomy of a patient's oropharyngeal space with other providers. It's important because patients who have a Mallampati score of class 3 or of class 4 are higher risk for both mask ventilation and for intubation. The way that you evaluate it is you have the patient at eye level with you, you have their head in a neutral position, you ask them to open their mouth, to stick out their tongue, but not to phonate, so not to say ah or make any noise, just to stick out their tongue. And then you look into their oropharyngeal cavity, and depending on what you see, you would grade it according to these different classes. I actually think that the easiest way to explain the Mallampati scoring system is to start on the high end, so with class 4. Now, class 4, that would be like a patient who is at higher risk for mask ventilation or for intubation. So when you ask them to open their mouth and stick out their tongue, what you would see in class 4 is you would only see the patient's hard palate. Then moving to class 3, so moving down the scale, you'd see the hard palate, just like class 4, but you would also be able to see the patient's soft palate, or another way to think of it is the base of the uvula. Class 2, you have the hard palate, you have the soft palate, but now you're able to see the fauces, which is the like cavity that leads to the back of the pharynx. And then you also can see the uvula right here as well, that's beginning to extend down. And then in class 1, you have the soft palate, or you have the hard palate, the soft palate, the fauces, the uvula. But importantly for class 1, it's kind of defined by being able to see the tonsillar pillars located right there. So moving back up the scale in class 1, you can see the tonsillar pillars. If you see tonsillar pillars, you're in class 1. If you can see the fauces or the uvula, but not the tonsillar pillars, you'd be in class 2. If you can see only the soft palate and hard palate, you'd be in class 3. And then if you only can see the hard palate, you'd be in class 4. The next component of the airway exam that I would like to talk about are the risk factors for difficult mask ventilation and for difficult intubation. Now, these are a variety of different exam findings, and these exam findings can be risk factors for both difficult mask ventilation and difficult intubation, or for just difficult mask ventilation or just difficult intubation. It's important that there's not really one of these exam findings that is incredibly sensitive or specific for mask ventilation, for difficult mask ventilation, for difficult intubation. So you really have to use them collectively. And then when you do an exam and you identify multiple of these risk factors, then that has a much higher sensitivity and specificity for identifying a challenging airway. So we'll start off with risk factors for both difficult mask ventilation and for difficult intubation. The first one that I'd like to identify is BMI greater than 30. And then this kind of goes hand in hand with like a thick neck circumference. So that would be a neck circumference greater than 40 centimeters. Next one is Mallampati score, which we were just talking about. Now you can kind of see the clinical significance um, of 3 or 4. Uh, poor jaw protrusion, so an inability to like pronavigate the jaw. So if you work with Dr. Iverson at Sanford, he always does this exam maneuver. What he does is he'll ask his patients to take their lower jaw or their bottom teeth and bite their upper lip. So they're sticking out their bottom jaw and trying to extend it to bite their upper lip. An inability to do this is a predictor of both uh, difficult mask ventilation, difficult intubation. Um, Next one is poor spine mobility, particularly in the cervical spine. And then, kind of like maybe a little bit more unique finding or a little bit more rare is a history of neck radiation. So if there's any scar tissue um, that decreases the flexibility of the neck, that can make it more difficult to mask, ventilate, or to intubate. Um, a couple risk factors for just difficult mask ventilation would actually be being male sex, um, edentulous, so having dentures or not having teeth. It was interesting in the Baby Miller textbook. They said that if you're having difficulty mask ventilating a patient who is edentulous, or if you suspect difficulty mask ventilating them, you could actually ask them to leave their dentures in if they were well secured. I've never seen this in practice. That could probably be a good question for your attendings if they've ever seen that or if they've ever done that to improve the ability to mask ventilate. And then this one is pretty intuitive, but if your patient has a beard, could be challenging to form the seal around their face and difficult to mask ventilate. And then a few risk factors for difficult intubation would be it's called reduced incisor gap. So all this is really saying is if they're not able to open their mouth very wide, then that could be make it more challenging to intubate, which makes sense. You just are working in a smaller space then. Um, and then thyromental distance, less than 6 centimeters. So this is the distance from like the mentum of the lower mandible, so like the end of the chin, to the thyroid. How that's measured in practice, what I've seen clinically is attendings, they'll ask the patient to place 3 fingers underneath their chin. And if they're able to place these 3 fingers, fit those there underneath their chin, between the end of their chin and where like their neck begins, then you can estimate that they have an adequate thyromental distance. If they're not able to do that, so if they have an atrophied mandible or atrophied jaw, or they just don't have much of a chin or jawline, then that could be an indicator for difficult intubation. Mask ventilation is an essential part of anesthesia. Dr. Nate Smith in Rapid City, he's an anesthesiologist. When I was first rotating with him, he said, I don't care if you know how to intubate, but I definitely care if you know how to mask ventilate because mask ventilation is what saves lives. I think it's a really cool point. Intubation's super flashy, but sometimes you can't intubate and you're forced to have to find a way to mask ventilate. Um, to be able to move any sort of air and keep the patient alive. It kind of starts maybe a step before your traditional mask ventilation with pre-oxygenation. So pre-oxygenation is just the process of saturating your hemoglobin with oxygen. So making sure that all of the hemoglobin is bound to oxygen. When you do this, a normal patient can then be apneic for about 9 minutes before they begin to desaturate below 87%. So I guess I would say the first process of like pre-oxygenation is going to be saturating your hemoglobin. So your hemoglobin. Um, the other aspect of pre-oxygenation, Dr. Toom at Sanford, he talked about so denitrification. His point here um, is more looking at the aspect of instead of trying to saturate all your hemoglobin with oxygen, you're trying to remove all of the extra nitrogen that's in your functional reserve volume within your lungs, and you're replacing that with oxygen. So not only are you building up an oxygen reserve on your hemoglobin, but you're also like acquiring more oxygen in your lungs by replacing the nitrogen that's in that reserve volume with oxygen. Mask ventilation is an essential component to anesthesia. When I first rotated with Dr. Nate Smith, he's an anesthesiologist in Rapid City, he told me that he didn't care if I knew how to intubate. He cared if I knew how to mask ventilate. His point was intubation is a very flashy process. It's a skill that everybody is chomping at the bits to learn, but sometimes you can't intubate and you have to fall back on mask ventilation. And being able to mask ventilate can be the difference between a patient living or dying. And proceeding down that difficult airway algorithm. So it's really important to be able to have proper technique and to know how to do that because it can save lives. Now, to me, mask ventilation starts earlier than the traditional one-handed mask ventilation. I think it starts with pre-oxygenation. So pre-oxygenation is the process kind of two things occurring. So pre-oxygenation, I think, kind of refers to replacing or saturating all of your hemoglobin with oxygen. So pre-oxygenation is saturating all of your hemoglobin with oxygen, making sure that all of the hemoglobin is bound to oxygen. And then there's another process that Dr. Toom brought up called denitrification. Now, this is getting at the same idea, but kind of from a different angle. So you're trying to replace all of the nitrogen that's in your functional reserve volume within your lungs with oxygen. So you're kind of approaching it from two different angles. So by saturating all of your hemoglobin with oxygen, that's increasing the time that a patient could be apneic. And then by also replacing all of the nitrogen in your lungs with oxygen, that's also increasing the amount of time that a patient could be apneic. Now, to do this, there's kind of two different approaches. So you could ask your patient to breathe for 3 minutes of tidal volume breathing of 100% oxygen. That's equivalent to asking a patient to take 8 deep breaths in 60 seconds of 100% oxygen. Both of them are validated. Both of them are going to increase the amount of oxygen and increase the time that a patient has that they can be apneic. What you're looking for is an end tidal oxygen level. So that would read on your monitor. It's the amount of oxygen that the patient is breathing off. according to the Baby Miller, of above 90%. In practice and in a lot of studies, I've seen looking for an end tidal oxygen level of above like 87 or 88%. Another trick, like according to the textbook, this would be a good point to ask your attending about, um, would be elevating the patient's head when you're pre-oxygenating them. So if you sit them up at like a 25-degree angle, or if you place pillows or blankets underneath their head so their ear is at the level of their xiphoid process, that decreases the like compressed lung tissue, the atelectasis that's in the patient's lungs, and then that can also improve the amount of oxygen uptake and improve like the lung capacity, ultimately increasing the amount of time that the patient could be apneic. Now, um, in a healthy patient, after you pre-oxygenate them, they could be apneic for almost 9 minutes before desaturating to an oxygen level of less than 87%, which is a pretty remarkable amount of time that they could be apneic. The two caveats of patients who desaturate much quicker is going to be an obese patient, and then like healthy patient, but if they're a child. Um, the the study cited in the Baby Miller shows that um, an obese patient is going to desaturate to a level below 90% between 3 and 4 minutes, and then a child would desaturate to a level below 90% between 4 and 5 minutes. So definitely much much quicker, less than half the time that a child and an obese patient can spend apneic. So, a crucial aspect to mask ventilation is proper hand placement. Mask ventilation is a skill, it takes practice to learn. And one thing that's definitely tricky is knowing how to place the mask on a patient's face and not occlude their airway while still maintaining an adequate seal. So, I have a couple pictures included here to try and illustrate this process. So you can see right here in this picture, we have the anesthesiologist placing the middle finger, the ring finger, and the pinky, what should be on like the mandible of the jaw. What you want to avoid is putting pressure on the soft tissue, which he's doing. That can cause edema around the airway, but you can also directly occlude your airway just by like pressing directly on it. Another tip that I've been instructed on is to try to get this pinky right here, like directly on the angle of the jaw. Then you're going to take your pointer finger, your ring finger, and you're forming a C shape around the mask that applies counter pressure as you lift up with these three fingers. So you definitely want to have the mindset of lifting the mandible up into the mask, not pressing the mask down into the face. By lifting the mandible up, you're performing a jaw thrust maneuver, which opens up, ideally, opens up the airway of the patient. Um, After you get this like seal created, a few tips that I would definitely include are extending this arm. So this arm, it goes back up here. You want to extend that arm. Try not to be bent at the elbow and really hunched over the patient. The terminology that Dr. Toom used that I love is extending that arm like you're water skiing. So when you extend that arm, it just makes it a lot easier to really like lean back and then lift up the jaw here, and perform that jaw thrust maneuver better. Not only can you lift that up, but you can also, you like kind of start extending the neck a little bit more here, which also opens up the airway. Another thing that like made a big difference when I was trying to mask ventilate is this like C shape that you're forming. I was forming like a very wide C, kind of like that. And it made it difficult for my fingers to like control this aspect of the mask because my hand was like so far over to the like patient left. Um, as I watched Dr. Toom mask ventilate, his like C shape that he formed is a lot more narrow than I was doing. So it was, kind of like this. And when you make it more narrow, you're able to cheat your pointer and your thumb finger over farther onto the patient right. And in doing that, you gain more control of this aspect of the mask. And a really common area for a leak to occur is like right over here, kind of in the corner of the mouth. Um, Another aspect, if you have a leak, something to think about is you want to have a properly fitted mask. So that's shown pretty well in this image. Uh, you want the bottom edge of the mask to be sitting between the lower lip and the chin, and then the top edge of the mask to be on the bridge of the nose. Um, yeah, if you have too large of a mask, it's going to make it much harder to form an adequate seal. And they make different sizes masks that you can use. Uh, as you form this seal, and you lean back and you're able to feel like you're in control. You're then going to take your right hand over here, and grab the bag and begin to squeeze the bag to deliver like volumes, tidal volume breathing. Um, as you're doing that, then you'll take your focus, your head, and you're going to look at the monitor, and there's a few things that you can look for to see if you're adequately mask ventilating. So one is going to be the end tidal CO2. Um, let's see, I'll just write it down here, but your end tidal CO2. Uh, if you are not getting end tidal CO2, then you're not displacing air that's in the lungs and having the patient like inhale or exhale. You're not ventilating them. So you need to start thinking about what are going to be your next steps to try to ventilate the patient. Um, the next thing that you'll look at is volumes of breathing. So I mean, like a very rough, like estimate, but if you're able to deliver like maybe 300 to 600 milliliters per breath, maybe ideally around like 500 or so, and it varies dramatically for patients, certainly in pediatrics, but you can feel more confident that you're adequately ventilating the patient. And then the last thing is your pressure. So, um, kind of like the notion or the studies showed that the esophageal or gastric sphincter that prevents air from moving into the stomach or stomach from regurgitating back up into the pharynx has a seal that can withstand 20 millimeters of mercury of pressure or centimeters of mercury of pressure. Um, if you're delivering tidal breaths or as you ventilate, if you're exceeding 20 in your pressures, then you should begin to be concerned if you're having to use too much pressure to ventilate. So maybe your technique is off, or maybe you need to place an oral pharyngeal airway or change something because you could be forcing air into the stomach. Now, another way to control this is to adjust your pop-off valve. Now, that's the little dial that you see people turn as they're performing the intubation or the mask ventilation process, and turning that down to make sure that your pressure isn't exceeding 20. Now, if you're unable to ventilate with one hand, generally you'll move to placing an oropharyngeal airway. And then if you're still unable to ventilate, then generally you move over to performing a two-handed mask ventilation technique. So that's this guy over here. Um, two ways that I've seen to perform this. So, one is forming the same C shape as in like the single-handed technique, but then just mirroring that with the other hand. Now, I chose this picture in particular because Dr. Iverson at Sanford, he definitely prefers using a two-handed mask technique uh, in this maneuver where you're using the thumbs to apply the pressure onto the mask and then lifting with all your other fingers on both hands. I like this technique as well. I feel that you're really able to perform or create a nice seal here because your thumbs lie like longitudinally along the length of the mask. Um, but yeah, theoretically, you could perform a two-handed mask ventilation this way or just by mirroring the single-handed technique. So just to be clear, as you're mask ventilating and you're watching the pressures, you're making sure that they don't exceed 20 centimeters H2O. That's the correct units. I misspoke earlier. That will be preset on your monitor anyway, so you don't have to worry about it, but it's 20 centimeters H2O. Now, say you're performing a single-handed mask ventilation technique. You're having difficulty ventilating the patient. The next thing that you would consider is placing like a airway adjunct device, like a oropharyngeal airway or nasopharyngeal airway. The um, kind of the big advantage of a nasopharyngeal airway, if you're choosing to use one, generally they don't provide as good of a job in opening up the airway to improve ventilation. However, they're better tolerated by a patient that has an intact gag reflex, and that stimulus is less, so you're less likely to create like a laryngospasm, which could be particularly important in kids, is avoiding that stimulus in stage 2 of anesthesia, that OPA, an oropharyngeal airway, um, could cause. Now, that said, an NPA could still cause a laryngospasm, it's just less likely. Now, when you're placing these, the first thing that you need to do is properly measure them. So that's shown pretty well in this first diagram here. So the way that I was trained to measure these is from the corner of the mouth to the earlobe. And then that measurement, that distance is going to be the appropriately sized OPA. And then for an NPA, the measurement that I've seen is from the end of the nose to the earlobe. So it's showing a slightly different way to measure in this diagram, but you get the idea. And there's multiple ways. Another way to measure the OPA that I've seen is from the like front incisors to the angle of the jaw. There's various different methods. When you place these devices, so as you place an OPA, you would actually insert it into the patient's mouth upside down. So we'll say the OPA is right here, like this, and then there's the curvature. So you would in place, or you begin inserting this into the patient's mouth, and then as you move it down and you meet resistance, then you would begin to rotate it until ultimately it fit in the patient's mouth, kind of as shown here. The bite block here, and then straight curvature, and where it kind of reaches down towards like the patient's pharynx to prevent the tongue from occluding the airway. When you place an NPA, you'll first lubricate the NPA, the tube. Make sure not to place any lubricant on the end of the tube because then you're occluding your device that's supposed to open up your airway. And you'll really just take like this end right here has a bevel on it, and just place the bevel, the smooth part, towards the septum of the nose, and gently kind of insert it through the nasal cavity down into the pharynx. I said with the OPA, it can cause like a laryngospasm. It's more stimulating. The maybe the big contraindication for the NPA is going to be if your patient has coagulopathies or like low platelets or something, because as you insert the NPA, very commonly you'll cause like trauma and bleeding to the nasal cavity, and then you don't want to have an issue where you're unable to stop the bleeding that you just caused. Additionally, OPA can't be used on a patient that has an intact gag reflex, where in NPA, there's like YouTube videos of those being inserted on people who are like fully awake as they demonstrate it. There's no YouTube videos of people tolerating an OPA in any capacity while awake. After mask ventilation, there's generally two or three different common ways to manage the airway. So one is just allowing the patient to breathe spontaneously. That's ideal if they're able to do so, if there's no contraindications. The other two devices that are commonly used are a laryngeal mask airway, or an LMA, and an endotracheal tube. Um, there's different advantages and drawbacks to each of these devices. So, an LMA causes less hemodynamic changes when you place it. It's less stimulating to the oropharyngeal cavity when you're placing it. It also causes less coughing and bucking when you place it or when you remove it. You don't need to use any paralytics, and there's less laryngeal trauma. The big downside of an LMA is it's contraindicated if there's any increased risk of aspiration or regurgitation. So that could be in pregnant patients, that could be someone who recently just had a meal. Anybody who's undergoing an RSI is going to be using an endotracheal tube. Or anybody who's undergoing laparoscopic surgery, at least in the States, they'll all receive an endotracheal tube because the insufflation in the abdomen can cause an increased risk of regurgitation. An endotracheal tube is kind of considered the gold standard for fully securing the airway. Um, it allows peak airway pressures of greater than 20 centimeters of water. So the reason for that is you're applying that pressure only to the lungs. There's no chance that, or there should be no chance that you're applying that airway pressure to the esophagus and the stomach. So you're not going to be blowing air, ventilating into the stomach. It prevents aspiration once it's secured. So you'll insufflate or inflate the balloon around the endotracheal tube, and that prevents any like potential regurgitation from then being aspirated into the lungs. If you have a frequent need for suctioning, an endotracheal tube is a good choice. It allows for positive pressure ventilation. It's a really good choice if you're having surgery occur in any positions other than supine, because it's more secure in the airway. And then if you're also performing a surgery and the operation is like near the trachea or on the throat, an endotracheal tube is going to be a good choice. Uh, the downsides of an endotracheal tube is it's more invasive and it can be a little bit more challenging to place. That said, LMAs can definitely be finicky as well. But it takes a little bit more technical skill for an endotracheal tube. And if you are placing an endotracheal tube, you pretty much have to paralyze the patient to be able to insert it. Um, or usually you'll have to. So, if you're having a surgery where you can't paralyze the patient, or if it's a difficult airway, you're suspecting a difficult airway, then that could also present some of its own challenges. So finally, you've performed mask ventilation, and you've decided that you're going to do an endotracheal tube intubation. Uh, and to do that, you're going to need to visualize the glottic structures or the larynx. So that's going to be via laryngoscopy. When you're performing laryngoscopy, one of the big keys is setting yourself up for success. So the first thing, at least for me, I'm 6'2", I'm a little bit taller, is elevating the head of the bed, or elevating the bed as a whole. So the patient's face should be at about the level of my xiphoid cartilage. The second thing is placing the patient into the sniffing position. So the sniffing position relies on two different factors. One is head extension, and the other is head elevation. And the point of it is you're trying to align oral, the oral axis, the pharyngeal axis, and the laryngeal axis. So what that means is when you're trying to visualize the glottic structures, you need to look through the mouth. So that's going to be the oral axis. You then need to look through the pharynx. So that's going to be the pharyngeal axis. And then you need to ideally be able to look down or through the larynx. So that's the laryngeal axis. And to do that, you need to get all of these axes, here in alignment with each other to be able to visualize it, because you see in a straight line. So you can see, like, if the head is in just a neutral position laying on the bed, none of these axes are aligned very well at all. Your oral axis, if you just open their mouth, is looking straight down. You'll see like the back of their pharynx. Their pharyngeal axis is looking this way, and their laryngeal axis is looking up in another direction. So if you tried to intubate in this position, it would be very difficult to be able to visualize through the larynx, which would be sitting like this. You'd have to somehow be able to see up and around the corner. Um, so the most intuitive thing to me is then head extension. So you can see down here, if you perform just head extension alone, your oral axis is now looking like a little bit more towards your larynx, which is sitting right here. You have to make less of a corner to see, but it still isn't ideal. These axes aren't aligned. Um, so along with performing this head extension, you're also gonna want to elevate the patient's head. Now, what that's doing is kind of hard to see in this image, but when you elevate this patient's head, you're causing like a flexion of the lower neck along with the, like, where it connects or meets with the chest. And that's kind of, instead of your larynx then facing this way, your larynx now faces up this way. Um, so you're like aligning your laryngeal axis with your pharyngeal and oral axis now. So with the head extension right here, and then the head elevation, now you have an oral axis that's looking down, laryngeal axis where the larynx is now facing up, and then your pharyngeal axis is aligned with both of these. So you can imagine that this provides a much easier view if you're trying to see down into the larynx, where you're trying to place the endotracheal tube. If you align your axes like this, and this is ultimately known as the sniffing position. Um, so elevate the head of the bed and then perform neck extension, as long as the patient doesn't have any contraindications to that. And then head elevation. So that's just going to be using like pillows or blankets, placing those beneath the patient's head. Um, now, as you perform this, it's going to be really important as you're attempting to intubate that you're communicating exactly what you're seeing to your attending. They can't see exactly what you're seeing, they don't know exactly what's going on. So, being able to vocalize and describe what's happening is super important to make everybody feel more comfortable. So, like an example of that would be as you're holding maybe like a Mac blade in your left hand, and you scissor the mouth open, and then you insert the Mac blade into the patient's mouth. You might say, "Okay, I'm like inserting the blade into the patient's mouth. I'm at hard palate. I'm at soft palate. I'm at the base of the tongue. I've entered into the pharyngeal space. Now I see epiglottis. I've placed the blade of or the end of the Mac blade into the vallecula. I'm lifting up. Now I see vocal cords. And then it's important to be able to describe exactly what you're seeing when you say, like, I see vocal cords, because that could mean a couple different things. So, um, there's different grades of visualizing the vocal cords. Grade one is where you can see almost all or most of the vocal cords right here. You have a great view. You'll just place the tube right there, nice and easy. Grade two can be divided into grade 2A or 2B. This right here is going to be what I would consider a grade 2A view, where you have a partial view of the vocal cords. Grade 2B is where you only can see the arytenoid cartilage. So these two bumps at the base of the vocal cords. So if this epiglottis was hanging down farther, you would say I have a 2B view. Grade 3 is where you can only see epiglottis, right here. And then grade 4 is where you can't even see any epiglottis. So finally, you've placed the patient in the correct position. You saw a good view of the cords. You intubated the patient. Now you have to confirm correct endotracheal tube placement. So there's a couple different things. While you're in the operating room, um, the big one, the most important one, the gold standard for confirming endotracheal tube placement is end tidal CO2. Um, I've had attending Dr. Nesbitt in Rapid City. He told me, he said, you can watch for fog, chest rise, breath sounds, all these different things. But if I'm not getting end tidal CO2, I don't care. I'm not like feeling settled. We need to look and try to figure out what's going on. The other ones are kind of secondary or more clinical ways of confirming good endotracheal tube placement. So one is going to be bilateral chest rise. Um, and then similar to that, bilateral lung sounds. um, Watching for fog in the tube. Uh, I've had some attendings consider like visualization count as a point. So when you intubated, if you saw the tube pass through the vocal cords, then you could say that's another way that you've confirmed correct tube placement. And the Baby Miller actually references, maybe you would call it like cuff palpation. So now this might be easier on kids if they have a little bit less developed, like tracheal cartilage, um, or just a smaller amount of it. But when you inflate the cuff surrounding the endotracheal tube, if you have your hand resting on the outside of the throat, sometimes you can actually feel the cuff inflate in the trachea, and then that would be another confirmation. Um, if you're confirming with a chest x-ray, uh, it's a little bit variable on the criteria, but as a general rule, um, you'd be looking to see the endotracheal tube 5 plus or minus 2 centimeters above the carina. Um, if you have it too shallow, then you're at risk for accidentally extubating the patient. If you have it too deep, and it's resting on the carina, that's like extremely activating, like painful. Or you could also risk like doing a main stem intubation and then only ventilating one lung. So, lastly, when you're intubating a patient or performing laryngoscopy, sometimes it can be challenging as you're performing it, and you might be unable to obtain a good view of the glottic structures. Other times, you might just suspect that this could be a difficult intubation, so you might prepare using some adjunct devices like immediately from the get-go. So, we'll just cover three of these. The McGrath. That's a tool that uses video laryngoscopy. It's this guy shown here. The glide scope also uses video laryngoscopy. That's the most common one that I've seen in Rapid City and at Sanford. I've heard that Avera, they use the McGrath pretty commonly. And then a bougie, which is shown right here. Um, so the McGrath, it has the blade that curves down like this. You can have various different types of blades on it with different curvatures, sizes, angles, etc. And then it has a video screen up here. So it allows you, even if you can't directly visualize the glottic structures, you can see the glottic structures indirectly on the screen. A glide scope is very similar to the McGrath, except the screen that you're visualizing the glottic structures on is not attached to the handle. It would just be like a screen that could be like mounted to your IV pole or on like a rolling stand, kind of like an ultrasound screen. Um, Now, a few pointers when using at least a glide scope. So, when you're performing intubation using a glide scope, you're going to insert like the blade into the patient's mouth. Sometimes it can feel like a little bit larger blade, at least to me. So I was trained to hold like the blade, like so it's angled kind of laterally to the patient's mouth. Like the handle would be pointed off to the side, like towards the left cheek. And then as you insert it as far back as you can into the mouth, then you begin to rotate it so the handle is then pointed over the patient's chin. Um, you then find your view, and with the glide scopes at Sanford, they have a blade on there that's very similar to a Mac blade, and you use it like a Mac blade. So you insert the blade on the glide scope into the vallecula, you find and visualize the glottic structures, and then you take a endotracheal tube that's on a rigid stylet, and you insert it into the patient's mouth. Now, one of the biggest dangers of using a glide scope or video laryngoscopy is you're unable to visualize, or most of the time you're going to be unable to visualize the endotracheal tube all the way to the glottis, because like that's the whole reason you're using the glide scope, is you're having difficulty visualizing the glottic structures. So as you insert the endotracheal tube on a rigid stylet, you want to make sure to watch the tip of the tube as far as you can into the pharynx. So at this point, you're trying to maintain the view on your screen, but you're actually looking into the patient's mouth and watching as you insert the endotracheal tube. Now, the big complication that can occur is it's on this very rigid, strong stylet, and if you meet resistance and you're not able to see your tip and you keep pushing, then you could say you're performing it on this patient and you insert your stylet over here, and you can't see the tip of your stylet and you can't see it on your screen yet, but you keep pushing. You could drive the tube and the stylet into the retropharynx and puncture the retropharynx, and that's like a massive complication. So you want to be able to watch the tip as far as you can. Don't apply pressure if you're meeting too much resistance. And then find the tip on the video laryngoscopy screen, and then you can direct it into the trachea from there. Another pointer when you're performing a glide scope intubation, it's a rigid stylet that's being used. So you have this like endotracheal tube slash stylet right here. And it's very rigid. So if you want to have the most control, grasp the rigid stylet at the very top. That gives you the most leverage, so you can control like the tip and steer it the most effectively. Um, a bougie is not a video laryngoscopy tool. It's actually just this like yellow portion here without the endotracheal tube. Um, and what you would do is, say you're having difficulty intubating the patient. Well, you take this bougie and you would pass it down through the oral pharynx until you see, say, the epiglottis is hanging like this. And the tip of the bougie, which you can see here, is angulated. It's angulated like anteriorly. So what you do is you would pass your bougie down like this, and then it's angulated up, and hopefully that helps direct it into the trachea, um, just like is shown in this diagram. And once it's in the trachea, this tip, theoretically, it rubs on the rings of the trachea as you pass it down, and you can feel that like tactile response up here where you're driving the bougie. So if you feel like vibrations or rubs as you're passing the bougie down, you know you're in the trachea. Where if you passed it into the esophagus, it doesn't have any of those like cartilage rings, so it would feel smooth. You wouldn't have that responsiveness, and you would anticipate or think that you are in the esophagus. And once you place the bougie into the trachea, all that you do is just take the endotracheal tube, like is shown in this diagram, and you feed it over the top of the bougie, and then the bougie directs the endotracheal tube into the trachea like that. I hope that this helps, guys. Let me know, or Dr. Toom, anybody know if you have any questions, and we will see you in the next lecture.